Hello, your COPD patient just came in, confused, leaning forward, using accessory muscles to breathe. Their ABG comes back and the PCO₂ is 78, pH is 7.28, SpO2 hovering at 84 on room air. The doctor says, BiPAP now. Do you know exactly what to do next? Do you know what settings to start with, what to watch for, and what it means if they're not getting better in the first hour? Stay with me, because in this video, I'm giving you the complete stepwise protocol for managing acute hypercapnic respiratory failure in your COPD patient on BiPAP, from the moment they arrive, to the reassessment, to knowing when to escalate. Let's start with the why, because if you understand what's happening in the lungs, everything else makes sense. In COPD, there are two main problems happening at once. First, air trapping and dynamic hyperinflation. These patients can't fully exhale. CO2 builds up with every breath. Second, they have increased work of breathing against elevated airway resistance and stiff, overinflated lungs. When this tips into an acute exacerbation, we call it acute on chronic hypercapnic respiratory failure. The CO2 climbs above their baseline, which is already elevated, and the pH drops. The body cannot compensate fast enough. That's when they decompensate. This is exactly the scenario where NIV, specifically BiPAP, has the strongest evidence. And I mean level 1 evidence. Multiple randomized controlled trials, including the landmark Brochard 1995 study and the GOLD guidelines, all support NIV as first-line therapy. Before you put that mask on, 60 seconds of smart assessment, this saves lives. You need to quickly confirm that this patient is a candidate for BiPAP. Not every patient in respiratory distress should go on NIV first. Some need immediate intubation. If any of these absolute contraindications apply, go straight to the airway. If none of those apply, your patient is a candidate. Grab your baseline data right now: ABG, RR, SpO2, heart rate, and mental status. The ideal candidate has a pH between 7.25 and 7.35, a respiratory rate over 25, and accessory muscle use. All right, patient is a candidate. Let's set up. Choose your interface first. For most acute COPD patients, a full face mask is your best first choice. They're mouth breathers in distress. Nasal masks won't cut it. Start with an IPAP of 10 to 12, an EPAP of 4 to 5, and a backup rate of 10 to 12 breaths per minute. Now, a critical point. You want SpO2 between 88 and 92%, not higher. Over-oxygenation can blunt their drive and worsen CO2 retention. BiPAP is not set it and forget it. You need to reassess every 15 to 30 minutes and titrate based on what you see. If the RR is still over 25, increase IPAP by 2 centimeters of water. Target a range of 14 to 20 centimeters of water as needed. Watch your 5 targets: respiratory rate, tidal volume, accessory muscle use, mental status, and SpO2. Improvement in mentation is a great sign. Knowing when to stop and escalate is just as important. Do not sit on a failing patient. Watch for these red flags. If the pH is worsening, RR is climbing over 30, or mental status is declining, escalate immediately. Prepare for intubation. BiPAP works with a treatment bundle: bronchodilators, systemic corticosteroids, and antibiotics if a bacterial trigger is suspected. And don't forget, secretion management. Clearing the airway can completely change the trajectory of a patient who appeared to be failing NIV. In an LTAC, account for deconditioning and polypharmacy. Document everything. Your assessments are the quality record. Success means a pH returning towards 7.35, RR below 22, and the patient staying alert and comfortable. Assess quickly, set up correctly, titrate aggressively in that first hour, and run the full treatment bundle alongside. This systematic care saves lives. This is respiratory care made simple. Subscribe, and I'll see you in the next one.